Alright, rheumatology, let's go. Diagnostics. So we got that. But we start with heme, and then we'll move to rheum. A 45-year-old female presents to a local doctor with a 3-week history of easy bruising, menorrhagia. This is associated with fatigue and intermittent fever. On examination, she was pale and thin. She had prominent ecchymosis. Spleen was tippable beneath the costal margin, and there was slight bony tenderness over the sternum. Given the presence of menorrhagia, ecchymosis, pallor, and splenomegaly, I'm concerned about a malignancy of the blood cells, particularly that of a leukemia, and I could divide this based on the patient's age. It could potentially be acute myeloid leukemia. I'd like to also exclude acute lymphoid leukemia and chronic leukemias, including chronic lymphocytic leukemia and chronic myelocytic leukemia. Other differentials for ecchymosis could include causes of thrombocytopenia, and this could be immune thrombocytopenia purpura, idiopathic thrombocytopenia with purpura, heparin-induced thrombocytopenia, and I'd like to also exclude coagulopathies, hemophilias, and causes of enlarged spleen could include congestive causes such as portal hypertension, could be secondary to liver disease, infectious causes such as EBV, CMV, HIV, hepatitis B, neoplastic causes, and autoimmune causes such as rheumatoid arthritis, lupus, and Klinefelter syndrome. What would you ask on history and exam? That's not a commonly asked question, so we'll pause it there. Upon history, I would like to characterize the bleeding. She mentions that there is menorrhagia. I'd like to characterize whether this is intermenstrual bleeding, heavy bleeding, and whether there are triggers for this. I'd be concerned about all the causes of bleeding. Could be polyp, adenomyosis, and be looking for any signs of malignancy, constitutional symptoms. Easy bruising. I'd like to know whether the bruising can be caused by a trauma event, or whether it's simply occurs. I would like to determine whether this has happened before. And given the ecchymosis in places such as the arms, I'd be concerned about DV. I would like to determine if she's taking any medications such as anticoagulants that can predispose to this. And family history, I'd be looking for any family history of autoimmune conditions like lupus, rheumatoid arthritis, and just do a quick psychosocial screen and confirm that this is caused by medical reasons. What investigations would I perform? I would perform my diagnostic investigation of choice for an acute leukemia, given that the 3-week onset of symptoms, is Likely that of a bone marrow biopsy, looking for the presence of blasts with greater than 20% blasts indicating acute leukemia. Other investigations include bedside investigations. I could do bedside VBG, looking for any evidence of shock, any acidosis. I could also do a full blood count, looking for a picture of pancytopenia, as it's indicated with her ecchymosis indicating thrombocytopenia, and pallor indicating anemia. And I'd be looking for any lymphopenia or lymphocytosis. I would then do blood film, and in ALL I might notice blasts, and in AML I might notice blasts with rods indicative of myeloperoxidase in the blast cells. I could then proceed to doing coags, given the patient has abnormal coagulation, so APTT, PT, INR, and bloods could also tell me that she's febrile, given fever, and I could then do biopsy looking for, I could also do specific leukemia studies, such as flow cytometry looking for abnormal surface markers. In ALL I'll be looking for CD10, 19, 20, and I could also do cytogenetics looking for any genetic abnormalities such as the BCR-ABL 922 translocation indicative of chronic myelocytic leukemia, and also seen in some subtypes of ALL. Okay, can you interpret this? Full blood count, hemoglobin is low. Patient is anemic, and there is a normocytic anemia with leukocytosis, lymphopenia, neutropenia, and thrombocytopenia. And there are myeloid precursors in the blasts, and this is indicative potentially of an acute myelocytic leukemia. And blood platelets are derived from megakaryoblast, which will then develop into megakaryocytes, and cytoplasmic blebs of these megakaryocytes will form platelets. And they usually circulate from about 8 to 9 days before destruction of the spleen. What are the pathophysiology, risk factors, and complications of AML? AML occurs due to a mutation which arrests your myeloblastic cells in the myeloblast stage. And as a result, they cannot further proceed and differentiate into your monocytes, your granulocytes, your erythrocytes, and thrombocytes. As a result, they can accumulate in the bone marrow and crowd out the production, decreasing the production of other blood cells such as erythrocytes and thrombocytes, normal thrombocytes. And this leads to your clinical picture of increased infection risk, thrombocytopenia causing petechiae, purpura, ecchymosis, and anemia. The risk factors for AML can include radiation exposure, chemical mutagens such as heavy metals, any alkylating agent which can damage DNA, ionizing radiation, and complications of AML can include complications due to the pancytopenia. As we mentioned, there's increased infection risk, there is an increased bleeding and bruising propensity, and there is anemia. And then we can think about complications due to invasion. We may get AML spreading to different parts of the body. It can deposit in the skin and gums, causing disease in those locations. It can also move to the brain, causing a CNS leukemia. It can have some ocular involvement. It can also cause irritation of serous sepsis, causing a pericarditis, for example. And then we are concerned about metastases and distant seeding. What is the prognosis? AML typically carries a good prognosis, as for all leukemias. Management through chemotherapy could be about 50-60%, I'm guessing. So let's see. $70 to 80% and 50% if they're above 60. 70 to 80% if they're less than 60. I've got genetic risk factors. It can be genetic risk factors such as Downs, Turner's, myelodysplastic syndrome, Downs, Turner's, benzene from smoke, benzene, DNA alkylating agents, cyclophosphamide, DNA alkylating agents can cause leukemia, benzene can cause it, high dose radiation, pancytopenia, spread, CNS, ocular, pericardium, tumor-related due to lysis. We mentioned that tumors can lyse and it can cause a hyperkalemia, which we're concerned about. And it can cause acute pulmonary failure. It can be renal tubular damage as your monocytic leukemia. The monocytic leukemias can be rich in lysosomes, can damage the kidney tubules. So to summarize again, the complications of AML include complications due to the pancytopenia, complications due to spread, and complications due to the tumor and associated destruction of distant tissues. Was I just stupid in saying that leukemias can't be called metastatic? Yeah, I was stupid. It rarely forms solid tumors, it stays in the blood. Staging. Doesn't form solid tumours. Staging is funky. It's just early common early pre-B cell, common pre-B cell, mature B cell. Could be pre or mature. Makes sense? Not really. That's for most of medicine. Right, done HIV and AIDS. Why did he get dysphagia as oral candidiasis? What are my differentials for patient with generalized rash, sore throat, malaise? This patient is generalized unwell and has lymphadenopathy. I'm concerned about infection. Could be HIV, could be hepatitis B, could be cytomegalovirus, Epstein-Barr virus. I would also be concerned about other causes of a rash. Syphilis can cause a rash. Sore throat, I'd be concerned about other causes of URTI. With majority of your pharyngitis being caused by viruses. And yeah, what else would you be concerned about? Toxoplasmosis. Generalized lymphadenopathy. Well, what are the causes of generalized lymphadenopathy? Infectious, EBV, CMV, inflammatory infiltrative causes such as sarcoid. Sarcoidosis can cause malignancies such as lymphoma. Other causes of a rash such as syphilis, hepatitis, rubella. It's lupus, sarcoid, Kawasaki's disease. Kawasaki's disease. Sarcoid, amyloid, Kawasaki's disease. So infectious causes include, let's see if I can get it all, malignancy. I did mention lymphoma. I should be concerned about lymphoma if he has generalized lymphadenopathy. Come on. So simple. Okay, and then rubella. Okay, in a patient who is generalized unwell, in a patient who's generally unwell, I'm concerned about causes of lymphadenopathy. These include infectious causes such as HIV, cytomegalovirus, Epstein-Barr virus, toxoplasmosis, rubella. Given the patient has a rash, I'm also concerned with syphilis. And other causes of lymphadenopathy can include inflammatory causes, including systemic lupus erythematosus, infiltrative causes such as sarcoid, malignant causes such as lymphoma, that's it. Why does he have dysphagia? We mentioned that he has oral candidiasis. What's an A defining illness? Cytomegalovirus, retinitis, HIV, encephalopathy. Can be a tuberculosis infection, invasive cervical cancer, cryptosporidiosis, Nemesis gyromecca pneumonia. Oropharyngeal candidiasis, toxoplasma encephalitis, cryptococcal meningitis, cryptosporidium diarrhea. Oh my lord, so many things these HIV patients can be affected by. So types of AIDS-defining illnesses I'm concerned about: Kaposi's sarcoma, cryptococcal meningitis, any tuberculosis infection, cryptosporidium diarrhea, pneumocystis jirovecii pneumonia, CMV retinitis. So I'm concerned about CMV retinitis, HIV encephalopathy, cryptococcal meningitis, TB, pulmonary or extrapulmonary. I think I've got enough. What is AIDS? CD cell count less than 200 and an AIDS defining illness, as we've mentioned here. What investigations be relevant? Chest X-ray for TB, PCR for EBV, CMV, latex aggregation test for cryptococcus. Within abnormalities. Okay, it's RNA retrovirus, TB. You wouldn't do the mailto test because they don't have a strong enough immune response. You wouldn't do quantiferin gold because it's looking for specific. It's quite the same, but you're not using peptides that are in the mailto test. Serology, TB, CMV, cryptococcus. Okay. HIV. How does HIV work? It's an RNA retrovirus. It's transmitted via venereal spread. It's uptake by dendritic cells and presented to T helper cells. And it binds its glycoprotein 120 to the CCR5 or the CXCR4 receptor. And GP41 will then assist with membrane fusion and entry. A sneaky virus. So it binds its GP120, this CD4 receptor. Then it will dock by attaching to the CCR5 receptor. Then GP41 will connect to the host cell membrane and enable fusion and entry. HIV is just bad. Primary infection falls, CD count elevates, this up. Oh my lord. We typically use 2 NRTs and 1 NNRT. PrEP is entrisitobine. It's in PrEP. tenofovir and emtricitabine. That makes sense. You give tenofovir here as well. Just add efavirenz. Never heard of that in my life. So, your typical triple therapy includes 2 nucleoside reverse transcriptase inhibitors, and this can include emtricitabine and tenofovir. And then we can give a non-nucleoside reverse transcriptase inhibitor, which binds to a different site, 2 nucleoside reverse transcriptase inhibitors. And this includes efavirenz, emtricitabine, tenofovir, efavirenz. Okay. And how is Western blot formed? It's a gel electrophoresis of proteins where we are looking for specific proteins associated with, we're looking for antibodies. Okay, so we're looking for primary antibodies. I'll bind to antigens. Western blot with HIV. Western blot is going to bind to the HIV. Separates blood proteins and looks for HIV antibodies. And they're 95% accurate. Western blot detects a positive ELISA. So ELISA is enzyme-linked immunosorbent assay. It's where you add an antibody that binds to an antigen, but the antibodies then bind to a fluorescent dye. But in Western blot, so your ELISA is done first. If positive, then we do Western blots. Western blot, we add antibodies directed towards HIV serum antibodies, and they are bound to a fluorescent dye, and then we undergo electrophoresis in view of fluorescent dye. Okay, let's do von Willebrand's disease. For that, let me study. Wait 2 minutes. Ain't nobody got time for that. Maybe you can all hear what I'm hearing. You want an ASMR approach. I hope I ain't copyrighted. Oh no, that can't be.
secondary hemostasis stabilizes the platelet blood, and that's all mediated by that complex thing called coagulation cascade. So with this little bit of introduction, we can now move forward into disorders. The first step is what I want to talk about hemostasis. Now, of course, to understand these primary hemostasis disorders, you really have to understand why primary hemostasis. So let's go there. Now, when there is disruption of the blood vessel, and of course, the blood vessel endothelial cells sit on top of a basement membrane. When there is disruption, as I've drawn here, the very first thing is a little bit of a knee-jerk reaction. So step one of this primary hemostasis will be that there will be transient vasoconstriction of the damaged vessels. Now this is very important to note because actually examiners like to go after it. Step one, the blood vessel will actually rapidly constrict. I think of it as a knee-jerk reaction. When you get an injury, you kind of pull away from something. I don't know if you touch something hot, you pull your hand away. When the blood vessel gets damaged, it just clamps down very quickly. And that perhaps is to decrease the amount of blood supply going to the region for a moment before hemostasis can begin. Or it might also be that the blood vessel is sort of just shaking itself to awaken. Now, you need to know for the purposes of examinations that this step one is actually mediated by two things. The first is neural stimulation, so it's a neural reflex for the blood vessel to clamp down when there's initial injury. And number two, and perhaps a little more high yield, is that the endothelial cells themselves have a molecule called endothelium. So that when this endothelial cell, for example, is disrupted, endothelium will be released, and that will cause a very quick transient vasoconstriction of the damaged vessel. Now the next step is that von Willebrand's factor will come in and will line the surface of the area of disruption at the level of the.
There we go. Von Willebrand's factor. And take off this and switch to this. We ain't about to be copyrighted again. Okay, so we begin with blood vessels that, lined with endothelium, an injury to those blood vessels will trigger to cause a vasoconstriction, and that's going to be mediated by endothelium, which is released by endothelial cells. So, number one, vascular injury will result in number one, ural vasoconstriction, and number two, we'll also get endothelin release. Endothelin, that's going to constrict. That also causes vasoconstriction. And then what happens after that? Where's our... Okay.
Or hemostasis and related disorders. This is our first section. It's an introduction. It lays the framework for the rest of the chapter. The idea here is that we need to recall that we've got blood vessels, endothelial function. The way I remember the two most important is that the endothelial cells have von Willebrand's B1b. Now you realize that when the endothelial cells are disrupted, we've now exposed both have a molecule called endothelium. So that when this endothelial cell, for example, gets disrupted, endothelium will be released, and that will cause a very quick transient vasoconstriction of the damaged vessel. Now the next step is that von Willebrand's factor will come in and will line the surface of the area of disruption at the level of the subendothelial collagen. Now you realize that when the endothelial cells are disrupted, we've now exposed both the basement membrane, which contains collagen, as well as the connective tissue underneath, which contains collagen. That collagen then allows for von Willebrand's factor to actually bind. So von Willebrand's factor will bind, and then von Willebrand's factor will act as a linker molecule for the platelets to bind to this region. And the way by which the platelets bind is by using a receptor called GP1B. So the platelets will...
Okay, so then we get exposure of the we get subendothelial collagen exposure, as we mentioned. That normally releases prostacyclin, subendothelial collagen, and plus von Willebrand factor receptor has been exposed. Therefore, von Willebrand's factor can bind to it. Right, so therefore number two, we're going to have a blood vessel, and the same principle. Now we have exposure of the von Willebrand's factor, and platelet glycoprotein 1b will bind to this GP1b. No, GP1b binds to von Willebrand's factor. GP1b.
we use GP1B to bind von Willebrand's factor, and that is called platelet adhesion, and it is step number 2. Platelet adhesion, the platelets bind von Willebrand's factor via GP1B. Important to note for the purposes of examinations, where does von Willebrand's factor come from? Von Willebrand's factor comes from two sources. Number one, the platelet itself has some von Willebrand's factor within it, but number two, and the most important, is that the endothelial cells have von Willebrand's factor themselves, and so the vast majority of the von Willebrand's factor actually comes from the endothelial cell. Unfortunately, that's not sufficient. You do need to know one more thing, and that is that within the endothelial cell, it's the Weibel Palade body that actually holds the von Willebrand's factor. Remember that the Weibel Palade body is something that we learned about in normal histology. It is a body that is viewable by electron microscopy, and it contains many different substances necessary for endothelial function. The way I remember the two most important things within the Weibel Palade bodies is to use the letters to remind me of what's actually in them. So for example, the P reminds me that one of the important molecules in the Weibel Palade body is P-selectin. And remember, P-selectin, its role was important when we talked about the selectin speed bumps in our inflammation discussion. So I'm not going to go into the details here, but those P-selectins were important there. And the W helps me to remember that von Willebrand's factor is also contained within the Weibel Palade bodies. Now that was step 2. Once this binding occurs, then the next thing that happens is the platelets get activated, they undergo shape change, and then they degranulate. And so that is step 3. So adhesion of the platelets to von Willebrand's factor will then cause a shape change within the platelets, which then allows for the dumping of mediators that are going to be necessary for moving this process forward. And there are two important mediators that are going to arise from the platelets. One is going to be ADP. And ADP is essential. And the second is going to be thromboxane A2. And remember that thromboxane A2 is a derivative of platelet cyclooxygenase, and that's high yield. ADP is present within the dense core granules, and thromboxane A2 is a derivative of platelet cyclooxygenase. Now, the important things about ADP and thromboxane A2, ADP induces the platelets to express another receptor, and the other receptor is going to be something called GP2B.
Okay, so there's a GP1B. Okay, so once platelets bind to your von Willebrand's factor with a GP1B, then we will get right. So GP1B binds to the von Willebrand's factor. So is von Willebrand's factor always, is there a receptor? Let's see. Where is that found? Let's see if I get a good diagram. Okay. Oh, it's a shit diagram. I'm just gonna see this. Okay. Von Willebrand's factor, GP1B binds to von Willebrand's factor. Is that normally, is there a receptor for von Willebrand's factor? There's your Weibel Palade body, which has P-selectin and von Willebrand's factor. There is a platelet, and your damage to the endothelium results in exposure of von Willebrand's factor, and platelets will bind to von Willebrand's factor. Okay, sure. Exposes, whereas so you don't cram junior med school to glycoprotein is ultra large in the endothelium. Line inside the surface of the blood vessel. Yeah, I don't think there's any receptors, so there's vascular injury, and there's now von Willebrand's factor is exposed in the subendothelial collagen. Okay, what happens next?
Okay. Now GP2B3A receptor, as you said?
GP is GP1B and then GP2B3A. Jesus Christ. Okay. Platelet binding to von Willebrand's factor results in two things happening. Number one, we get ADP release from granules, and then we also have platelet cyclooxygenase converts into thromboxane. cyclooxygenase converts itself into thromboxane A2. Right, and
Potential for platelet aggregate A2, ADP. Now the important things about ADP and thromboxane A2, ADP induces the platelets to express another receptor, and the other receptor is going to be something called GP2B3A. Now, GP2B3A receptor is essential for platelet aggregation. Aggregation is when all the platelets join together at this particular spot. Remember that adhesion was a platelet binding to the area of exposed subendothelial collagen via von Willebrand's factor. Aggregation is when the platelets begin to aggregate on top of those adhesive platelets. So ADP is essential for the expression of GP2B3A. And then TXA2, thromboxane A2, will be the signal that will allow for further platelet aggregation. So platelets will begin to aggregate here, and one important thing to note is that the important linker molecule that the platelets use to aggregate to one another is called fibrinogen. So this important linker molecule here is called fibrinogen, and that again is essential to know as well. Okay, so with that in mind, let's read a little bit of our text. So I say that primary hemostasis occurs via 4 steps. In the very first step, we get transient vasoconstriction of the damaged vessel. This is mediated by reflex neural stimulation and endothelium, which comes from the endothelial cells. Step 2, you get the platelet adhesion to the surface of the destructive vessel. Again, von Willebrand's factor will bind that subendothelial collagen. The platelets will bind that using GP1B. Where's von Willebrand's factor come from? From the Weibel Colloidal bodies and from the platelets, in particular the alpha granules of the platelets. Now then, that will cause platelet degranulation. So the adhesion will cause a shape change, which then results in degranulation with release of multiple mediators. Remember that ADP, which comes from the dense granules, then promotes the exposure of GP2B3A on the receptor of the platelets, and thromboxane A2, a derivative of cyclooxygenase, very high yield again, derivative of platelet cyclooxygenase, further promotes platelet aggregation. And platelet aggregation is going to occur via GP2B3A using fibrinogen as a linker molecule. Now, important to note, and I've already stated that this results in the formation of a platelet plug. That platelet plug is weak. It doesn't have the ability to withstand a tremendous amount of force. And so, in order to further stabilize that platelet plug, we're going to undergo secondary hemostasis, which basically is the job of the coagulation cascade. But of course, in this particular section, we're dealing with disorders of primary hemostasis, so we're not going to focus on the coagulation cascade yet. That's going to come up a little bit later. Now, what about disorders of primary hemostasis? How can we think about those? Well, those are basically, for the most part, not always, but for the most part, they're going to be due to abnormalities in platelets. And there's 2 types of abnormalities that we can have in platelets. We can have a quantitative abnormality where we don't have enough platelets, the quantity is bad. Or we can have a qualitative problem where the quality of the platelets is no good, but we have enough platelets, for example. And so these are the 2 ways we want to think about disorders of primary hemostasis when we're in the context of abnormalities of the platelets. Quantitative disorders and qualitative disorders. Now, when patients have disorders of primary hemostasis, they're going to present with some very classical signs and symptoms. And the most important is that they're going to get mucosal and skin bleeding. This is the predominant picture of a patient with a disorder of primary hemostasis. So what are some examples of mucosal bleeding? Well, any mucosal site can bleed. For example, a patient can have nose bleeding or epistaxis. They can have coughing up of blood, or hemoptysis, GI bleeding, hematuria with blood in the urine, or menorrhagia, heavy menstrual bleeding because the endometrium is also a mucosal surface. So these are some classic signs and symptoms, and actually the most common is epistaxis, and that's why I sort of went after that one and highlighted it for you as I was talking. Now, one of the fear complications of having a low platelet count is intracranial bleeding. So this occurs when there is severe thrombocytopenia. So that's something to just bury away in the back of our minds that mucosal bleeding is not so bad, we can deal with it, but the fear complication is that as the platelet count goes down, for example, if there was a quantitative problem with platelets, then intracranial bleeding would, the risk of intracranial bleeding would increase, and we become more and more worried about that particular complication.
Right, so worried about skin mucosal bleeding. We're worried about skin mucosal bleeding, and particularly we are concerned about other signs of bleeding, such as menorrhagia, which is particularly at the endometrial level. And we are also concerned of bleeding in the intracranial if severe. Okay, next.
For example, patients can develop petechiae or pinpoint bleeding in the skin. They can develop purpura, which are slightly larger, measuring approximately 3 millimeters or greater. And finally, they can develop ecchymoses, which measure approximately greater than 1 centimeter. And so these are varying sizes of bleeding within the skin. Now, I'd like to alert you to the point that there is an error in your text here, and that the size of purpura and ecchymoses has been reversed. So again, purpura are greater than 3 millimeters, and ecchymoses are areas of bleed greater than 1 centimeter in the skin. Now, another symptom of skin bleeding might be easy bruising. In patients with thrombocytopenia or patients, what I might say, with disorders of primary hemostasis will also exhibit easy bruising. Now, one of the important things to note that when we talk about petechiae, ecchymosis, and purpura, when we get this type of bleeding, we're really talking, it really is a sign of thrombocytopenia. And what I mean by that is, remember, when we talked about the disorders that could arise, we said there can be a quantitative disorder of platelets or a qualitative disorder of platelets. So patients who have qualitative disorders of platelets, they normally don't get petechiae. However, patients who have quantitative, where the number is down, they get petechiae. And so that's a little, that's just a little side note to be aware of. This is what petechiae look like. They're these little tiny bleeds that are exhibited on the skin here. And so this is the classic image of petechiae. You can see here that perhaps we're getting into the possibility of having a little bit of ecchymosis here, where the bleeds are slightly larger as well. When a patient has a disorder of primary hemostasis, you've got mucosal bleeding, you've got skin bleeding, then you're going to want to look at some laboratory studies in order to try to determine where the problem is. So, for example, the platelet count can be very helpful. It tells us how many platelets there are. If we had a qualitative, i.e., probably the number of platelets, of course, the platelet count could be the normal platelet count is anywhere from 150 to 400,000, 150,000 to 400,000 per microliter. Less than that, we would begin to potentially see problems, especially when the platelet count is less than 50K or 50,000. The bleeding time is also a useful laboratory study. The bleeding time, basically, the idea here is that you prick the patient and you see how long it takes them before they stop bleeding. The normal is anywhere from 2 to 7 minutes, so normally in about 2 up to 7 minutes, the patient stop bleeding. However, when there's quantitative problems or qualitative problems, the bleeding will be prolonged. And so that's the bleeding time. Now, the reason why I argue whether that's useful is perhaps most places in the country wouldn't be doing this anymore. It's a little bit of a primitive test, but it does show up in examinations, so I kept it in your text. Next way by which we can assess the patient's platelets is to look at them, and we can do that by blood smear. You take the patient's blood, you smear it on the slide, and you get a peek at what the platelets look like. It helps you to tell how many platelets are present. We can assess the number of platelets, at least in rough estimate. We can assess the number of platelets by looking at them on the slide, and we can also assess the size of the platelets. And you'll see that there will be some disorders where the size of the platelets will matter, and so that is how the blood smear will be helpful. And then finally, we can do a bone marrow biopsy to assess the platelets. And the way this works is that remember that the megakaryocytes are the cells that are actually producing the platelets. So we can ask the question if, for example, platelet count is low, are there megakaryocytes? Maybe it's that we don't have megakaryocytes in the bone marrow, and that's why the platelet count is low. So the bone marrow biopsy is also very helpful. The first of the disorders that we want to discuss is called ITP. This is an autoimmune production of IgG against platelet antigens. For example, one of the antigens on platelets is GP2B3A. Remember GP2B3A?
Okay, so von Willebrand's disease, woman comes in, 18-year-old woman, wisdom tooth extraction, uncontrolled bleeding. She has heavy menstruation. On examination, she's pale, so she's got pallor. So potentially anemia, thrombocytopenia, and cool extremities. Concerned about the causes. So malignancy, right? It's a disorder of primary hemostasis, given there's skin bleeding and menorrhagia and signs of anemia. So you're concerned about primary hemostasis because skin and menorrhagia you consider primary hemostasis, and it can be due to multiple causes for thrombocytopenia. It can be immune thrombocytopenia purpura, IgG against platelet antigens such as GP2B3A, which prevents cross-linking of the platelets, splenomegaly. Let's go back to our little diagram so we understand how that all connects right there, and we'll go down to maybe 1.5 speed. Okay, I think you've all heard enough. Just going for time. Might do 20 more minutes of work, you know, why not? Already here. Might do one. Make it 124. Yeah, I think I'll go back to my head settings. So I'll put it back in my headphones. GP2B3A. Ah, right. So von Willebrand's factor, which is released by the normal circulating endothelium, the Weibel-Palade bodies, but also from the actual platelets themselves. So let's just say exposed subendothelial collagen. Collagen. What does this case have for what the differentials are for your von Willebrand's disease? Okay, so I'm concerned about stabilized but likely von Willebrand's disease. Bruising, menorrhagia, it's a sort of primary hemostasis, differential diagnoses. Could be due to bone marrow failure, immune thrombocytopenia purpura, could be IgG antibodies. It can be hemolytic uremic syndrome. It can be heparin-induced thrombocytopenia. So when you're concerned about thrombocytopenia, there are a few causes. We're concerned about low platelets and then dysfunctional platelets. Let's go through what he explains. Chelating von Willebrand's factor binds to the exposed subendothelial collagen. Because of skin bleeding, epistasis. Epistasis is the most common. Bleeding. Destroyed. Okay. Oh no. Normal platelet count, normal PT, PTT. corticosteroid. Right. Eat this instead. Microangiopathic hemolytic microangiopathic hemolytic anemia. Thrombus. Thrombotic thrombocytopenic purpura. So you get a microangiopathic hemolytic anemia, a microangiopathic meaning small vessel, hemolytic anemia because there are hemolysis of the red blood cells, and it causes your schistocytes. It causes schistocytes, which are sheared cells, and we also notice red blood cells which have hemolyzed. And the causes for that include number 1 and number 2. Number 1 is your TTP, thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura. Right, and the other one is hemolytic uremic syndrome. See. symptoms. Schistocyte, shared red blood cells in the kidney. Makes sense. Oh, 157A7 virotoxin. Beef. E. coli 051787. Decreases atoms, TS13. Damages the kidney. Microthrombi. There's a microthrombi. However, if it's a woman, I'm concerned about. In ITP, it's mainly brain. Mixed it's mainly kidney. Okay. Patient bruising. Bruised. Okay. Hemorrhagic clinical thrombocytopenia. Peter Purpura to von Willebrand's disease. Celiac syndrome, genetic causes. Bernard-Celiac syndrome. Bernard-Celiac. Bernard. Adams TS13. Bernard-Celiac. Big circus, big platelets. ADP produces GP2B, 3A. Irreversible. So you can't produce thromboxane A2 on aggregate platelets. Anemia. It can be due to genetic causes, such as Bernard-Celiac syndrome, Bernard-Celiac disease. Yeah. GP1B, Glanzmann's thrombasthenia. GP. Von Willebrand's disease. Okay, so I'm concerned with platelet disorders, splenomegaly, platelet dysfunction due to aspirin-uremia, Bernard-Celiac disease, coagulopathies too. Whew. Holy smokes. GP1B binds to one von Willebrand's factor. For ADP thromboxane, it would be GP2B 3A. 3A. It's produced by ADP. That's fibrinogen. So basically, if I'm concerned about biomedicine, biomed, if I want to know biomed, and if I see a case with bleeding, in fact, primary hemostasis, when do I know it's primary hemostasis? If I see epistasis, menorrhagia, skin, mucosal bleeding. Okay, so if I see epistasis, skin, mucosal, menorrhagia. Okay, what investigations, what would my differentials be first? Well, my differentials would be disorders of thrombocytopenia. And what are the causes of thrombocytopenia? Well, they can be decrease in quality of platelets, number of the platelets, and decrease in the quality of the platelets. And if I'm concerned about decrease in the number of platelets, then I can consider conditions such as number one cause, which is ITP, in which we have IgG to platelet GP to platelet antigens. Platelet antigens such as GB1B. Right, and you can see it typically in children, or you can see it in autoimmune conditions in older women. Then you can have a microangiopathic hemolytic anemia, hepatic hemolytic anemias. So what this tells you is that there are microthrombi forming in these blood vessels, and as a result you'd see it typically in you typically see it in is it ITP immune? Yeah, TTP. Thrombotic thrombocytopenic purpura. It's caused by Adams TS13 antibodies, which decrease its levels, which are important for cleaving it. And you can have secondary hemolytic uremic syndrome, in which you get virotoxin depletes thromba platelets in kidney. Then you can have quality, so we have genetic causes, Glanzmann's thrombasthenia, we could have Bernard-Souliers, we could have Glanzmann's thrombasthenia, and then you can have your meds. So meds, there can be three conditions. Aspirin. Aspirin's a cyclooxygenase inhibitor, and we can have conditions. Uremia. We know that uremia can cause. So that's thrombocytopenia in a nutshell. So what about secondary? Coac. Hemostasis. and we need fibrinogen to fibrin to get a stable clot. Deep tissue. And then it goes back up to 7. What times 2 times 5 is 10. 10. 5 times 2. APTT. PTT. It's the intrinsic pathway. Sub-lymphadenopathy. Tissue thromboplastin. Heparin is PT. INR is warfarin. Hemophiliate. Mutation. Oh, that makes sense. So, what is secondary hemostasis? Well, it goes from factor 12 to factor 11 to factor 9 to factor 8 and activates factor 10. And then factor 7 will activate that. A subendothelial collagen will activate factor 12. Subendothelial collagen. And tissue thromboplastin will activate factor 7. So that's your extrinsic. And your intrinsic is your subendothelial collagen. Call that intrinsic. And so it activates as such. and then that activates 5, 2, and 1. It's 5 times 2 times 1. Right, 1 is fibrinogen, is fibrin. And we check this via the APTT. You check this via the PT. We know that because APTT is the intrinsic pathway. Done. Von Willebrand's disease itself, there we go. PTT is normal, but APTT has normal factor 8 now in patient plasma. APTT in hemophilia. In autoimmune, it'll be low. APTT because antibodies bind. Decrease factor 8. Okay, I'll take a 5-minute break. Let's do 20 more minutes. How about that? Let's do 2 o'clock then. 11 more minutes. Because man's got to eat. Let's go. Yeah. Two instructions. Thyroid. Carboxylation. From gamma carboxylase to 7910 CNS. NSAIDs, TK Pepra. So 7, 10, and you block epoxide reductase and vitamin K deficiency. So gamma carboxylation, vitamin K deficiency. It can happen due to decreased diet. It can happen due to antibiotics. Change in microflora. And it can happen in liver failure. Let's decrease epoxide reductase. Okay, so genetic cause hemophilia A and B, autoimmune, secondary hemostasis. So to sum it all up, it can be, and then it can be secondary hemostasis, it can be secondary hemostasis, it can be genetic, via hemophilias. There's no category as such, just your hemophilia, your von Willebrand's disease, vitamin K deficiency, hemophilia, genetic, autoimmune, von Willebrand's, genetic, autoimmune, von Willebrand's disease, and vitamin K deficiency. That can be genetic in the setting of factor 8, factor 9, to 8 antibodies. Willebrand's disease stabilizes factor 8. Factor 8, vitamin K deficiency, decreased diet, liver disease, and then decreased consumption. Liver disease, consumption. Okay, null PT, extrinsic pathway, test tissue factor, which is tissue thromboplastin. Right. Tissue factor. Tissue factor. Now, protein CNS, they're going to inhibit factor. What to factor 2? Protein CNS inhibit factor 8 and factor 5. Thrombin. And then thrombomodulin. Eight and factor 5. So protein C. Protein C. It's usually protein C plus thrombomodulin modulin, and protein S can activate protein C, and protein S is going to go and inhibit factor 5, factor 8, and thrombin will also go and activate factor 5 and factor 8, and it's going to lock up protein C. Okay, so I've got that down pat. Right, coags, prolonged APTT, factor 8 deficiency. Overpressed circulating active factor 8. Factor 8 is not found, it rapidly degrades. And Lebrun's binds to circulating factor 8. Inactive factor 8. Factor 8 is not found, rapidly degenerates. Factor 8 is needed in the last step. Stabilize factor 8. Carrier protein of factor 8. Factor is bound to one of the brain's factor inactive. Degrades rapidly. Right. Genetic autoimmune von Willebrand stabilizes. Circulating factor 8 bound to von Willebrand's factor. Therefore, if there's no von Willebrand's factor, therefore there's going to be a decrease in factor 8 as it degrades. It's a carrier protein. Okay. Ristocetin cofactor assay. Functional von Willebrand's factor. It's prolonged in this case. Clinical history. Ristocetin test. Ristocetin tests. IX. Ristocetin test. Cause this one to platelet receptor GP1B. Normal blood. There. Ristocetin. Factor assay. Ristocetin. Binds GP1B. It binds platelet GP1B to von Willebrand's factor. So you do the cofactor assay and it's positive. It's prolonged. Cofactor assay is prolonged in von Willebrand's disease. Tests functional von Willebrand's factor. And then there is the direct test. Yeah. C10. Platelet egg. Aggregation test. Subtypes. Looks for subtypes. TB variant. Von Willebrand's factor. Okay. Glutination. 1B. GP1B binding site of von Willebrand's factor. The normal to GP1B does not have factor 8. Factor 8. And then Bernard's syndrome. Describe one von Willebrand's disease. It's inherited bleeding disorder. It's 1% prevalence. It's one of the more commonly diagnosed heavy menstrual bleeding, bleeding from the mucous membranes, bleeding from wounds, menorrhagia, autosomal dominant. It's a mild defect. Type 2. There's 3 types. Autosomal dominant. It's 2A and 2B. Multiples are not synthesized. It's hyperfunctional. Type 2B is hyperfunctional. Type 3 is autosomal recessive. There's actually no von Willebrand's factor. No musculoskeletal bleeding. Yeah. You treat them with desmopressin. Versus the Weibel Pilates body's endothelium. Okay, tranexamic acid. It's antifibrinolytic. Fibrinolysis, antifibrinolytic therapy, tranexamic acid, or E-aminocaproic acid, tranexamic acid. Von Willebrand's factor and factor 8, concentrate. What are the different types of bleeding disorders? There's sort of primary and secondary hemostasis, and for the products, serotonin, ADP, platelet aggregation, and the constriction, extrinsic pathway, tissue factor X with an active factor. Tissue thromboplastin is tissue factor, or factor 3. Tissue factor, factor 7. X with inactive factor 7. 7. Hemophilia. X-linked, recessive, soft tissue, cryoprecipitate. When do you consider blood transfusion? Hemoglobin less than 70 or less than 90. What are some adverse reactions? Immunological, ABO incompatibility, can be infectious, can be volume overload, and they can be a urticaria anaphylaxis, type 2 hypersensitivity, antibodies, incompatibility, general type 2 hypersensitivity. Alright, let me give this one case a go. So what is it now? It's 209. Let's go to 218. Let's see. 8 minutes and we're done. Alright. Alright, let's go. Let's see how good I am with hemostasis after this study. Took one case, took this long. Jesus Christ. So what happens when you don't know Jack? Right. Right. Von Willebrand's disease. Get our timer. Reset. Start. 18-year-old woman is brought by the ambulance with uncontrolled hemorrhage following extraction of a wisdom tooth at a dentist surgery. She'd always bruised easily and often experienced heavy menstruation. So increased bleeding. There's no evidence of infection risk, no evidence of anemia, thrombocytopenia. There's been no previous operations. She's pale, anxious, chest, cool extremities. What are my provisional differential diagnoses? My provisional diagnoses, given the patient has uncontrolled hemorrhage following wisdom tooth extraction, would be that of a secondary hemostasis issue, and this could be something including hemophilia, A or B. I'd like to exclude von Willebrand's factor, possibly also vitamin K deficiency. Other differentials could include differentials of primary hemostasis, and these can be divided into issues with decreased platelet number, such as immune thrombocytopenia purpura, a microangiopathic hemolytic anemia, which can be secondary to thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome. Also like to exclude genetic causes, Bernard-Solier syndrome, Glanzmann's thrombasthenia, and I'd like to also exclude malignancy given the presence of pallor and potentially thrombocytopenia, which could be a symptom of leukemia and is consistent with the patient's age, possibly an ALL, for example. Would I ask on history and examination? On history, I'd like to know whether there has been any previous episodes of hemorrhage, bleeding, what the triggers are. I'd be concerned about domestic violence. I would like to determine whether the patient has any other systemic conditions which puts them in risk of bleeding. Should be liver problems, kidney problems, which can disrupt the hemostasis pathway due to hyperuricemia. I'd like to know if she's on medication such as aspirin, which can inhibit the formation of the platelet plug. If there's any family history of hemophilia, von Willebrand's disease, which is autosomal dominant. Hemophilia is usually sex-linked recessive. And psychosocial gain would just be concerned of DV. What investigations would you order? My diagnostic investigation would depend on the type of study being done, but to determine the primary hemostasis pathway, I'd like to get full blood count looking at platelets. Secondary hemostasis pathway could evaluate using coagulation studies such as APTT, PT, INR. I'd like to also look at APTT and PT. I'd like to also get a blood smear looking for any characteristic cells. We might be concerned with looking at blasts consistent with leukemia, and I could also consider bone marrow biopsy if I am concerned of leukemia or to reinforce my diagnoses. What investigations? What does this show? Full blood count depicts a microcytic picture of anemia, and hence I'd like to also potentially do iron studies. And there's poikilocytes, which can be present in iron deficiency. Okay, I can see that APTT is elevated, which is consistent with hemophilia. It can be a factor VIII deficiency secondary to genetic or autoimmune condition. You also see von Willebrand's factor antigen is very low, and this could indicate von Willebrand's disease, and that's consistent with the increased APTT, as von Willebrand's factor is a carrier protein for factor VIII. Ristocetin cofactor assay is low, which indicates that it's a test for von Willebrand's disease. So this abnormality could point towards one von Willebrand's factor. Histocectin typically helps bind platelet glycoprotein to the von Willebrand's factor. So the fact that it's low could indicate that there's not functional von Willebrand's factor present. What describe von Willebrand's disease? Von Willebrand's disease is a disorder of von Willebrand's factor, which binds to subendothelial collagen and assists in binding with glycoprotein 1b on platelets and assists in primary hemostasis and also secondary hemostasis through stabilizing factor VIII. It is the most common bleeding disorder, and it would typically present with skin and mucosal bleeding, for example, epistasis. There could be a menorrhagia seen in this patient, petechia purpura, for example. It can be specifically identified through the Histocectin tests, and there are multiple subtypes for von Willebrand disease. There is your typical autosomal dominant von Willebrand's disease, and there is type 2A, 2B. I believe 2B is due to a hypermutation of von Willebrand's disease, where the factor binds with increased affinity to platelet factor 1b, GP1b, and it is typically managed with desmopressin, which is going to result in contraction of the Weibel Palade bodies and the endothelium releasing more von Willebrand's factor. What are the types of bleeding disorders? Bleeding disorders can be divided into bleeding disorders of primary hemostasis and bleeding disorders of secondary hemostasis. With primary hemostasis, the main bleeding disorders include, as mentioned, an immune thrombocytopenic purpura and then a microangiopathic hemolytic anemia, which can be secondary to thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. There are also genetic causes such as Glanzmann's thrombasthenia, Bernard-Soliers syndrome, and there are also systemic symptoms such as renal disease and aspirin use, which can decrease thrombocytes. And regarding secondary hemostasis, there is your hemophilias, which can be genetic. There's your hemophilia A and B, factor VIII and factor IX mutation respectively, sex-linked recessive. There is your antibodies to factor VIII that can occur. There is also genetic. There's von Willebrand's disease and vitamin K deficiency. When would you consider blood transfusion hemoglobin less than 70 or less than 90 with deterioration, the hemodynamic instability of the patient? Typically less than 90. What are some adverse reactions to blood products? There's ABO incompatibility, generalized type 2 hypersensitivity reaction, as we can produce antibodies to antigens on red blood cells. There's risk of infection, and there's risk of an allergic response such as anaphylaxis. And I understand von Willebrand's disease. Von Willebrand's, you increase your bleeding because there's some issue with von Willebrand's factor, which prevents your platelets in primary hemostasis and prevents factor VIII from stabilizing. And on that note, I am done. So I've done how many hours have I done? I'm so close to 3 hours. I'm gonna suck it and do 3. Yeah, so close. Might as well, hey. Do 5 more minutes. And we've done hem-onc diagnostics, we've done Hodgkin's lymphoma. I'm going to go through that case myself. Nodular sclerosing, mixed lymphocyte rich, lymphocyte depleted. It's a bimetal distribution. Typically it's 15 to 35, greater than 55. There's cytokines, there's more contiguous lymph nodes. This factor is EBV. this human T cell lympho HTLV. T cell lymphotropic virus, human T cell lymphotropic virus, EBV, autoimmune conditions, Hodgkin's, immunophenotyping. All cells have CD30. It's usually metastatic lymphadenopathy is bifocal age distribution. How do you stage it? The Ann Arbor system. How's it staged? Why is it more important? It's managed with radiotherapy and chemo and adjunct to radio, to ABVD. And non-Hodgkin's is your R-chop. Hodgkin's has better outcomes. Let's try our Hodgkin's. See how good we are after doing the case of Hodgkin's too. Let's see. Okay, 23-year-old female presents to GP with 4-week history of dry cough following an upper respiratory tract infection. On exam, several tender large lymph nodes were found on the right side of the neck. There's no visible evidence of pharyngitis. It's my provisional differential diagnosis. Non-tender enlarged lymph nodes you consider malignancy, even in this age group. What other causes of enlarged lymph nodes is infiltrates such as sarcoid infections such as EBV and autoimmune conditions. What would I ask on history? Examination will I perform? Investigations. Okay, my differential diagnosis, given the presence of several non-painful lymphadenopathy and previous ERT-like symptoms, would be that of malignancy, and lymphoma would be my primary concern. I'd like to distinguish lymphoma into Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma typically would have a more mediastinal lymphadenopathy, carries better outcomes, and is managed differently. And histologically, you'd see Reed-Sternberg cells. In non-Hodgkin's, there's more. Start again. That's not what the question asked. They asked for your provisional differentials. Come on, man. So there's ERT symptoms, dry cough, tender large lymph nodes on the neck. There's no evidence of pharyngitis. So my provisional diagnosis would be that of a lymphoma, given the presence of non-painful lymphadenopathy and previous ERT symptoms, which could link to an infectious cause that could act as a mutagen. I am concerned potentially of a non-Hodgkin's lymphoma, given the presence of ERT symptoms. The patient may previously have had an EBV or CMV infection. Okay. Other causes of lymphadenopathy include infection, so CMV, EBV, HIV, hepatitis may also cause generalized lymphadenopathy, inflammatory causes, so your lupus, SLE, rheumatoid arthritis, infiltrative causes such as sarcoid, and I'd like to also exclude pharyngitis as mentioned here, which can be due to multiple pathogens such as adenovirus, coronavirus, picornavirus. And would you ask on history? I'd like to characterize the type of dry cough, tell me whether it's potentially a respiratory problem such as an infection, ERT, so fever, shortness of breath. So the enlarged lymph nodes, I'd like to know how long they've been there. Longer presentation could point to potentially malignancy. Shorter presentation could indicate that it could be infectious, for example. I'd like to ask screen for any autoimmune conditions the patient might have. Ask if she's on any medication that may cause a reactive lymphadenopathy. I'm not sure of any. And family history of any cancers in general. And psychosocial hygiene practices. Yeah. And sexually transmitted infections, given HIV is a concern. What investigations would I perform? Diagnostic investigation to diagnose a lymphadenopathy would be that of a biopsy. So it could be a percutaneous biopsy of a lymph node and associated architecture to determine if there is malignancy. I'd begin with a full blood count, looking for signs of infection, and I could also do rheumatoid factor or ANA if I'm concerned of malignancy. Then I could proceed to swab of the nasopharynx, microbiology study looking for signs of infection, and given that I'm concerned about malignancy, I could also do serology, looking for IgG, IgM antibodies. If I'm concerned of CMV, I could do the heterophile monospot test, and I would then proceed to biopsy, and imaging could include a CT chest abdo-pelvis if I'm concerned of infection. Came back with the mediastinal mass. Mediastinal masses are seen in approximately 50 to 60% of patients with a Hodgkin's lymphoma, so I'm more concerned of a Hodgkin's lymphoma. How has the diagnosis changed? Interpret the full blood count. Patient's anemic. It's a normocytic anemia, chronic disease. There's an elevated ESR, which indicates that potentially red blood cells have lost their charge, and that's due to the presence of proteins or other cells that may impair the negative charge in red blood cells, which has increased their sedimentation rate. There's reticulocytes, so this indicates that there is some reactive bone marrow hyperplasia. There's some increased bone marrow activity to compensate for this anemia. To do an excisional biopsy as opposed to a fine needle. So fine needle aspirate does not provide us with information of tissue architecture, whereas excisional biopsy would, and that may be important in addition to diagnosing the Reed-Sternberg cells seen in Hodgkin's lymphoma. So yes, I would like to do an excisional biopsy. What would you see under the microscope and lead you to think Hodgkin's lymphoma? So characteristically with your Reed-Sternberg cells, these are cells which have a bilobed or owl-eyed nucleus. They may have nucleolus as well. That have darkly stained chromatin, and the Asian cell might appear a bit paler. And there's variants of the Reed-Sternberg cell that we'd also be looking for. What information should you include in the pathology request? Pathology request would include the patient's condition, age, MRN, and what my concern is for my differentials that I'd like them to look for. What is nodular sclerosing? Nodular sclerosing Hodgkin's lymphoma is the most common type of Hodgkin's lymphoma. There are multiple different subtypes. There is your nodular sclerosing, your mixed, your lymphocyte rich, lymphocyte depleted. Each carries a slightly different outcome for the patient, and there is a different histopathological view. For example, nodular sclerosing, you'd see sclerosing bands of fibrosis. Compare Hodgkin's and non-Hodgkin's lymphoma. Well, Hodgkin's lymphoma is characterized by histologically Reed-Sternberg cells on excisional biopsy of the lymph node, and we would also, it carries a better prognosis, and due to the fact that there is a more contiguous spread of this malignancy, we would opt to using radiotherapy in stage 1, and then later stages we may consider using chemotherapy with the RCHOP, chemotherapy with the ABVD algorithm. Whereas your non-Hodgkin's lymphoma, there is a non-contiguous spread lymph nodes, carries a poorer prognosis, and you typically don't see mediastinal lymphadenopathy. As mentioned, there's a non-continuous spread in lymph nodes, and there are multiple different types, including your diffuse large B-cell lymphoma, your mantle cell lymphoma, your margin lymphoma, and your follicular lymphoma. Good. How do you stage it? We'd stage Hodgkin's lymphoma using the Ann Arbor staging system. So this includes stage 1, where there is an extra alveolar site, one single site, or there is one site of a spread to one lymph node, one side of the diaphragm. Stage 2 is when it's spread to one lymph node above and below the diaphragm. Stage 2 is then spread to more than one, so 2 or more lymph nodes on the same side of the diaphragm. Stage 3 is when it's spread to 2 lymph nodes, more lymph nodes above and below the diaphragm, plus minus an extra lymphatic site, and more than one extra lymphatic site, such as a spleen, is indicative of a stage 4 Hodgkin's lymphoma. Non-Hodgkin's lymphoma can also be staged with the Ann Arbor system, but it's more difficult to stage given that it's a non-contiguous spread. How does histology affect staging? Well, histology affects the grading, in which we have the degree of anaplasia and dysplasia of the cells, and this could lead to poor prognosis and require more scrutinized staging. Why is it more important to stage Hodgkin's lymphoma compared to non-Hodgkin's? Not contiguous spread. It's harder to provide reliable prognostic indicators with staging. How are they treated? Hodgkin's is ABVD, non-Hodgkin's is R-CHOP. Hodgkin's is chemo, non-Hodgkin's could be radio. Prognosis of Hodgkin's lymphoma, it's over 90% in young patients, so 18 to 30s, and then the older they get, it goes to about 80%. Non-Hodgkin's is lower, to 80%, and it's 95% if you're less than 40. So worst prognosis if it's lymphocyte depleted, best prognosis lymphocyte rich, worse if it's diffuse large B cell. Follicular. Follicular is good, diffuse large B cell, and mantle cell is bad. Diffuse large B cell, lymphocyte rich is good, lymphocyte depleted is bad. And it's kind of unpredictable. Histology is minimal effect on staging. Staging examines spread and symptoms, more useful and subtyping. So under Burkitt's, we've got Burkitt's. There's your Burkitt, mantle, B cell, margin, follicular. Okay, I think I understand Hodgkin's as well. A finished hemonc. My God, finished heme. So now, how many cases do I have left? I've done cardio, resp, I need to do gastro, I need to do gastroendocrine, psych, genitourinary. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. I'm only halfway through my cases, now 40 days to do 5. Why did I do this to me? Alright, I'm done. Okay. I'm done, I go to sleep. Thanks for joining.